I've been presenting at ANZOS since I did my honours for the last 15 years or so on ranging from isolated clinical trials to epidemiological research to evidence synthesis. And so I'm getting to a stage in my career where I'm trying to consolidate the different types of research I do into one large body of research and trying to sort of push towards the final translation stage of improved health outcomes. So I'm going to take you through the cycle that we practice at the implementation research group I work with now. And this is based at Monash University, and I also work within Adelaide University as well with the Robinsons, so I come back to Adelaide every few months to keep up my links here. So the Monash Centre for Health Research and Implementation is a collaborative centre between Monash Uni and Monash Health. And it's a very multidisciplinary group, so our group head is Helena Teed, who's an endocrinologist. Our deputy director is Jackie Ball, who's an ONG, but I'm a dietitian. We have exercise physiology, we have psychology, we have GP links, we have public health, health promotion, midwifery, nursing. So it's really meant to be about trying to capture the broader multidisciplinary nature of healthcare. And so we engage with government, with academic health science centres, uni faculties, NGOs, community groups and patients. And so we aim to have a broader creation, synthesis, implementation and translation approach to research. And we look at clinical and health services and public health research with the ultimate aim being to deliver improved health outcomes. And so we conduct research across a variety of areas. There's women's and children's public health research, also with a dedicated Indigenous health and refugee health program, diabetes and vascular medicine, and then research methodologies including across implementation and healthcare improvement. So I head the Healthy Lifestyle program within this team. I'm a dietitian by background, but we have Sue as a dietitian as a postdoc, and our other senior postdocs who are independently funded are Anju Johan as an endocrinologist and Cherise as an exercise physiologist. So really bring across that multidisciplinary aspect too. And our PhD students range from midwifery to health promotion to public health to endocrinology to dietetics as well. And so the broad aim of our group is to conduct research into optimising lifestyle and weight management across the continuum of lifestyle-related disease in women. So don't need to reinforce the importance of obesity management, but really just to highlight here that if we're looking at younger people, we have the opportunity to prevent established obesity at an early stage in life. And so just looking here at ABS data, we can see that even in women who are premenopausal, we have an obesity prevalence of up to almost 1 in 2. And since overweight and obesity are the second highest contributors to the burden of disease, it's very important to mitigate this as early in life as possible. And so just delving into this in a little bit more detail, so we've got quite good epidemiological data from the Australian Longitudinal Study of Women's Health, and there are 4 cohort waves that have been going through in over 40,000 women. But here we're just comparing the younger cohort who started out in their 20s and been followed through to their late 30s so far. And then the mid-age cohort started in their 40s and through to their early 60s. And over 16 years of data capture, we can see the young women are gaining 10 kilos over 16 years, and the older women are gaining much, much less weight. And then looking at this clinically, we can see that women in their late teens, early 20s, only 1 in 5 are overweight and obese. And by the time you get to your late 40s, it's up to 1 in 2. And there are a variety of reasons for this, but they can range to the change in prioritisation of health behaviours in women as they go across their reproductive lifespan, conditions such as pregnancy or postpartum, which can confer increased weight gain, or challenges in losing weight. So it really highlights the need to intervene as early as possible in life. So I focus on weight management in younger people, but also in women, because women do warrant focused research. They're not small men. You need focused research that actually takes into account the gendered approach to medicine. And one really nice example here is that women actually present with different symptoms prior to having a heart attack. And if they're not aware of this, you may actually have increased cardiac mortality because they're less likely to present to emergency and be treated appropriately. So there's good data in Australia and other countries that reproductive age women are the population group at highest obesity risk due to longitudinal weight gain. And then there are particular life stages in women that can confer additional burden. So across pregnancy, you may get an extra 4 kilos or so to add to that 10 kilos over 16 years, and the more children you have, the more weight you may maintain. Postpartum retention, maybe only 1 in 2 women can actually return to their pre-pregnancy weight, and that itself is associated with an increased risk of obesity and associated disease. And then you also have intergenerational effects. So both maternal obesity and also excess weight gain during pregnancy can both contribute to higher birth weight, childhood obesity, or a cardiovascular risk profile that can be maintained through the adolescence and adulthood. And so this may be due to biological reasons such as epigenetics and programming, or it could be due to the behavioural contribution of having a shared family environment of suboptimal lifestyle behaviours. There's also some advantages to working with reproductive age women as well, though, in that you have particular diseases which can be seen as triggers or warning signs to try and help women early in life, or at a stage where they're engaging more with the health system. So pregnancy itself is an insulin-resistant state, and that can act as a stress test and highlight the future risk of cardiometabolic disease. And conditions such as gestational diabetes or preeclampsia here are both associated on meta-analyses with a higher risk for diabetes and cardiovascular disease. And then a lot of my research has focused on polycystic ovary syndrome, but the reason for this is because it's a gender-specific disease which you can target and identify early in life, and this can confer a higher risk of obesity and also a higher risk of obesity-related disease. And it's also very common, it affects maybe 1 in 5 women. So just to summarise what we've talked about so far, in women, if you have a suboptimal lifestyle, this can contribute to increased weight. Where a woman becomes pregnant, she may also have a chance of having excess weight gain during pregnancy, and that can also occur in up to 1 in 2 women. And excess weight gain can both contribute to worsened child impacts. You can have increased risk of complications from excess gestational weight gain or excess maternal obesity during pregnancy, and these themselves can lead to a higher risk of future cardiometabolic disease. And when you have postpartum weight retention, you also have a future risk of adverse maternal obesity and associated complications. So there's actually been then quite a focus in national and international documents and policies really prioritising women's health research. So these include the National Heart Foundation Engaging Women Strategy, Department of Health and Ageing National Women's Health Policy, NHMRC Research Translation Call to Action has got a targeted call for preventing excess gestational weight gain, and also the World Health Organisation plans for non-communicable diseases. And so these all really prioritise that we should be looking at obesity prevention through preventing excess weight gain during pregnancy and postpartum, and that we should be targeting reproductive age women as a high-risk group with significant health implications. So this is the framework that we use at our research group, and this is what I've come to actually as a clinical and epidemiological researcher in my life in turn trying to consolidate the different facets of my research. So we look at having a multi-component approach to any of our trials, and we look at having a final scale-up and dissemination through to improve health outcomes at the public space. So we always start with formative research. We always start with stakeholder engagement, and this can be patients, this can be policymakers, this can be health professionals, and we identify the problem, we identify the patient or clinician perceived gaps, and we identify priorities and needs to maximise reach and effectiveness and sustainability. We then conduct evidence and knowledge synthesis around these identified gaps, and these can be systematic reviews, these can be evidence-based guidelines. We then, from these gaps and priorities, we conduct our co-developed efficacy research. And then following on from the results, we move to effectiveness research and implementation research. And where this is successful in a real-world situation, we then move to dissemination and translation scale-up, and then ultimately evaluation as well. So we try to make sure that we identify what is needed at every stage of the problem before we move to the later stage of the cycle. And it's an iterative cycle. We're always feeding back to the earlier stages based on our learnings. So for the rest of the talk, I'm going to talk about polycystic ovary syndrome predominantly, but this is because this is the area of research where I probably spent most of my career, and I feel that we've moved far enough along the cycle now to be working more successfully in implementation research. So this is very common, affects up to 1 in 5 women, but maybe 1 in 3 Indigenous women or 1 in 3 overweight and obese women. And it's classically diagnosed through 2 of 3 features, including menstrual irregularity and ovulation. Infertility is quite common too. Clinical or biochemical hyperandrogenism, so that's elevated circulating androgens such as testosterone, and then their effects on the clinical tissues such as hirsutism or acne, and polycystic ovaries on ultrasound. But there's increasingly a recognition of the metabolic and the psychological features that women with PCOS experience. So they have increased risk factors for type 2 diabetes and cardiovascular disease, and also increased prevalence. They have elevated obesity, abdominal obesity and insulin resistance, and they've also had worsened depression, anxiety and decreased quality of life. So insulin resistance here is really key. So insulin resistance is proposed to be present in PCOS in a form that's mechanistically distinct to that associated with obesity. So a lean woman with PCOS may still be insulin resistant. And then where she gains weight, she can further worsen this insulin resistance and have the compounded obesity associated effect too. So myself and Sue and colleagues conducted a systematic review a number of years ago, and we showed that there was a twofold risk also of women with PCOS being overweight or obese. So we can see that this is a population where they're more likely to experience obesity and the health effects, and therefore this will then worsen their clinical presentation further. But we've also shown positively that lifestyle management in PCOS from Cochrane reviews can actually improve the pathophysiological features in the clinical presentation. So here from a Cochrane review, which we're currently updating, we see that even though the literature is pretty limited when it comes to high quality RCTs, we still get reductions in fasting insulin as a surrogate marker of insulin resistance with weight management, and we get reductions in testosterone as a marker of hyperandrogenism. So weight management works in PCOS. So we know then that insulin resistance and obesity worsen, but weight management improves the clinical presentation of PCOS. But then to bring back here that weight management is more than weight loss and weight maintenance. It's about prevention of weight gain. And the earlier in life you work with women, you can actually try and make this a priority. And it's really quite useful even working with paediatric endocrinologists, such as our next speaker, Alexia Penner, to talk about her experiences in this population as well. And we come back again to the multidisciplinary nature here, so it's important for all the clinicians to work together with allied health, with general practice and with the women to develop their own healthcare plans. And so we've actually conducted evidence-based guidelines in this area, which were NHMRC funded and approved, and we released in 2011. And these emphasise lifestyle management as first-line treatment for PCOS, even for the reproductive and infertility implications. So just to jump back to the cycle of lifestyle-related disease in women, we can see that women with PCOS, we've identified adverse lifestyle at an early age. We can say that they can have a worsened sedentary behaviour, increased energy intake and barriers to physical activity. They're more likely to be overweight and have longitudinal weight gain. When they become pregnant, they're at an increased risk of pregnancy complications, as well as having an increased risk of cardiometabolic complications separate to this. And we're still conducting research into the longer-term maternal and child impacts as well, but these are likely to be perturbed as well. So this is the reason why I study PCOS, because it's a high-risk condition where women have a much higher burden of obesity and related disease, and where you can try and work with them as early in life as possible. And one thing about PCOS too is that it is one condition, and so for this reason it's actually been quite possible in Australia to bring together consumers and researchers and clinicians who have a passionate interest in this area. And so we've been working since 2008. We created the PCOS Alliance, which was to bring together everybody to make sure that we move forward with everyone's needs identified and the priorities for future research identified, and we're not working in competition anymore. And then we followed this up with getting an NHMRC CRE in 2013, and this has helped us to continue and combine our efforts. So just taking you through briefly then what we've done at each of these stages of the knowledge to action framework in PCOS. So this is research that's been done by colleagues of mine across Adelaide, so Rob Norman, Jodie Avery, and then also across Melbourne, Mel Gibson-Helm, Jackie Boyle and Helena Teed. And this is research working with women with PCOS, but also health professionals who work with women with PCOS. And there's quite interesting data showing that women's needs are not being met, that diagnosis is delayed, that it's frustrating. Women see multiple health professionals, their information needs during treatment are not being met, and clinicians themselves have gaps in their practice. Their current practice is not meeting evidence-based guidelines. And if we look with regards to lifestyle management as well, from some interesting UK data, we can see that lifestyle management, despite being first-line treatment, is only used by 1 in 4 European endocrinologists. It's used by far fewer obstetricians and gynecologists and endocrinologists. And even when it's used, it's often broad and variable and unstructured, and it's definitely not practical. So women often then have to go to non-evidence-based sources to meet these needs. And when it comes to allied health referrals, maybe only 1 in 3 clinicians would actually refer to a dietitian. So the needs of women with PCOS with regards to weight management are not being met either. Looking at evidence and knowledge synthesis, what we've conducted in PCOS. So a huge amount of work went into the evidence-based guidelines in 2011, and so Helena and Marie Misso are also conducting as leaders in the update at the moment. But even in the original guidelines, we did 27 systematic reviews to consolidate this work. And so this covered the areas of diagnosis and risk assessment, emotional wellbeing and models of care, lifestyle and weight management, which I was the chair for, and therapy for infertility. And these were NHMRC funded and NHMRC approved. And so we're now conducting the update, which again is NHMRC funded, and this is really to ensure the currency of recommendations, but also to see if clinicians and consumers feel we need to expand the recommendations to broader areas. But we're also going with an international focus this time. So we're actually already engaged with 18 professional societies nationally and internationally, and across each of the clinical groups and research groups that meets, we always have international representatives. And so we don't necessarily want to take the Australian guidelines and say that every international setting has to use them. There'll be a dedicated process for ensuring that they can be adapted to the local settings. And just as a little snapshot of some of my work that's actually contributed to the guidelines. So this is the very first talk I ever gave at ANZOS about 15 years ago. And this was as part of my PhD on lifestyle management and PCOS. And Rebecca Thompson here, around the same time, conducted a PhD on exercise interventions in PCOS. So between us, we conducted a nice body of work from clinical trials showing that weight management in PCOS improved reproductive outcomes, improved metabolic outcomes, and improved psychological outcomes. And we also looked at the dietary and the exercise components that form these successful weight management trials. So all of this research was encapsulated within the guidelines for lifestyle management in PCOS. So for myself as an earlier career researcher, it was nice to see the practical application of my earlier clinical trials. And evidence synthesis isn't just systematic reviews, it's also synthesising what's actually happening in care. So we're looking at existing models of care in PCOS and also existing resources. So we're assessing websites and apps, and we're seeing what's currently being done and how this can be improved. And so we published papers on this ranging from international settings such as the private healthcare system in Singapore, Indigenous settings in the Torres Strait Island, and we're also doing current evaluations of care across organisations such as Monash Health, Fertility SA or Jean Hales. So we're trying to work out what is actually working with current care before we then work to try and improve the models. So then moving through to new knowledge generation or our efficacy research. We have quite a large body of epidemiological research. So we've got 2 PhD students, Madeira, who's a public health physician, and Marnaz, who's a midwife. And between us and our collaborators across Queensland, Adelaide and Melbourne, we're really working on a wide variety of epi-data sets. So the RAIN study in Western Australia, the SCOPE study, we're working with Claire Roberts and Gus Decker in Adelaide, the Health Omnibus Survey in South Australia, and the Australian Longitudinal Women's Health Study as well. And just a snapshot again, because we published quite a lot, but we can see that from good quality epidemiological cohort studies, we're reinforcing the knowledge that there's increased metabolic complications in women with PCOS, new novel inflammatory complications such as increased asthma. We confirm that weight gain is actually increased over time in women with PCOS. Weight management practices may be abnormal in PCOS, so women with PCOS may be more likely to follow smoking or laxative use to control their weight, and that behaviours such as sitting time are higher in PCOS. So we use this knowledge of comorbidities as a way of then trying to target our future care to work out how we can best help women with PCOS and which lifestyle behaviours and clinical behaviours to try and help. And we're also working on knowledge generation to improve clinical practice. So Melanie Gibson-Helm and Nadia Khan are working on question prompt lists in PCOS. And these are structured lists of evidence-based questions which patients can take with them to their consultations. And it helps aid in shared decision-making and patient-centred care. And so there's a pilot underway of these being used by women and health professionals in Melbourne. There's also resource integration. So Marie Misso is working with an international team called MAGIC, or Making Grade the Irresistible Choice. And this is about how do you take the bulk of information in guidelines and actually integrate it into user-friendly formats and decision aids. And it helps consumers and clinicians interact with key messages. And then we've also conducted wide-scale synthesis of apps and websites, their current quality. And then when the guidelines are published, we will integrate that new information into new prototypes. So the final stage, I guess the last 10, 15 years of my research have contributed in small ways to aspects of that care. So what happens next? So at this very moment in Melbourne at Monash University, we have our pilot public PCOS clinic opening. So I'm here instead of there, which is a shame, but it'll be really exciting. So this is where we're actually taking our learnings and we're applying them to a co-developed multidisciplinary evidence-based model of care. And then we have the chance to conduct implementation research within this setting. So we'll look at RCTs of how the evidence-based resources are working. Do they meet the needs of women and health professionals? We conduct RCTs of different intensities of weight management, so weight gain prevention, or e-health as remote delivery, or even higher intensity lifestyle management programs. Can we find something that fits within the current Medicare referral plans? We have funding from the state government then to roll out the successful clinic statewide, and then from our partners, depending on the results, we'll have plans then to take it further to the national and even international setting with local context adaptation. And so at the moment, Steph Carotta and Gillian Tay are 2 PhD students, and they'll be working on this for the next 3 years, so it's a really exciting time. So in conclusion, I think from working as a dietitian in the multidisciplinary team, I really find that I have a lot broader scope for approaching any clinical question. I think it gives us a complementary way of approaching complex problems. I think we do need to move beyond isolated clinical efficacy research to look at what can improve broader effectiveness in translation and implementation of our findings. It's really crucial to focus on weight management and even weight gain prevention as a lower intensity approach in reproductive age women, and there can be real benefits for both women and their families and in breaking the intergenerational cycle of obesity. If we focus on key conditions such as PCOS or women who had prior gestational diabetes, it's a way of targeting a very wicked problem more manageably. And so we're in the process as well of applying a similar knowledge to action framework across research with women during preconception, pregnancy and postpartum. And so this is ongoing at the moment as well. So I'd just like to thank everybody I've worked with over the years who've contributed to this research and funding that's contributed as well. So thank you.